First off, welcome everybody. And this is an MS Views and News program called Symptom Management. It's about symptom management and shared decision making. You know, this is our 108th program this year. We have been here doing programs with you all now for about 20 years, okay? And we're going to just keep on going. All right, so today's program I already told you about. We're introducing Tricia Pagnotta. If you don't know who she is, well, she rides horses. There you go. She rides horses, and she's been very, very caring in the MS community for a very long time, and she's here to speak with you all today about this.
All right. Since you guys are back there and I'm up here, I hope you don't mind if I take off my mask. And just in case you're interested, Advent Health last year gave me a Christmas gift, and then they gave me a New Year's gift. And then they gave me a summer gift. So I've had all three of my vaccines. I've gotten 1, 2, and then my third was a booster. So I have been fully vaccinated, despite the fact that I look like a cowgirl standing in front of you. And just so that you all know, I would not wear this outfit, horse riding. So. But anyhow, I wanted us to be very relaxed. It's a Saturday. I wanted us to be very relaxed. And so I wanted to come and share with you some things that are important. And we will get moving right along. So Stuart asked me to talk about symptoms and shared decision making. So first, symptoms. When we talk about the symptoms of multiple sclerosis, it's very encompassing of many things. And just to let you know, not everybody gets all of these symptoms, and not everybody gets them to the same degree. So you all are snowflakes in Florida. So visual disturbances can occur, and that can be pain in your eye. It can be blurring of your vision. It can be graying of your vision, a loss of your vision, or actually double vision. Double vision would be something different, a different area of your brain than all those other visual disturbances, just in case. And so numbness and tingling is another symptom, weakness, balance, gait problems, fatigue, bowel, bladder. Then there are speech and swallowing difficulties, pain, spasticity, tremor, depression, cognitive difficulties, and heat sensitivity. And I am sure this is not inclusive of everything you've ever felt. But what it's important to know is that there is what we call a cycle of symptoms. And so I'm a very visual person, try to really help people understand things. And so what I try to explain to persons that if they come into my office and they have tons of things wrong with them, or they feel like there's nothing right, what I talk to them about is, well, let's look at one thing. Let's do one thing. If we can put one spoke in a spinning wheel, we can slow that down. And then we can work on the next thing and the next thing. But everything begets the next thing. So it's important to think about what can you do and what are things that are more manageable. So if you let one symptom get out of control, you might wind up having a symptom that you've never had before. In other words, let's say you have bowel and bladder difficulties, and you drink a cup of coffee before you go to bed. Well, I want you to know that bladder problems and caffeine that's not good, because caffeine is a stimulant to your bladder. So not only might that caffeine keep you awake at night, but it's also going to tell your bladder, hey, empty, and you might not really have much in it, but then you're awake all night. And so then you're fatigued, and you've been bragging to all your friends, I don't suffer from MS fatigue, and the next day you're as tired as can be. So it's extremely important to think about those type of things. So when we look at symptoms, again, I told you it varies between individuals, but what we categorize symptoms as either primary, secondary, or tertiary symptoms. So the primary type of symptoms are symptoms that occur because of the demyelination that is occurring in your central nervous system. So that is a direct result of what has happened because of your immune system attacking your central nervous system. Secondary symptoms are because of, but because of what happened in the primary. So falls, that's a secondary symptom. That's because you maybe had weakness, pain, or some other problem. Urinary tract infections, things like that. So these are symptoms that come because of number one, which is primary. And then tertiary symptoms, we obviously would like to always avoid these, but these are due to symptoms that you happen to run into because of 1 and 2. So maybe you're having financial issues because you have so many symptoms of primary symptoms that you're no longer working. Or maybe the stigma of being disabled and you don't go out and you don't socialize, and so therefore you become deconditioned and you fall. So again, the primary goal is to keep the primary symptoms as controlled as possible so that we don't get secondary or tertiary symptoms. And despite the fact that I'm now about to go on talking to you about symptom management, the underlying pinning is not to have symptoms. So the underlying goal is not to get symptoms. Well, how do you do that? You control your disease. Okay, so I'm here to tell you that unfortunately at this moment in time, this is not a curable disease. It's a long-term chronic disease that we have many therapies for. And so there should be a therapy that a person who has MS can take. Talk to your healthcare provider about that. But how you keep from getting primary symptoms is by managing your disease. So if we move on to talking about at least one symptom, let's talk about pain. And pain is a very common symptom of MS. And I wanted to accentuate this because most persons, when they're thinking about symptoms, at least the family unit, when they're thinking about the person's symptoms with MS, they are looking at the things that they can see. And people can't see pain. You can tell your family members that you're in pain, but they can't see that. And so we do know that up to 65% of persons with MS will suffer from pain. The causes of pain can include the inflammation and demyelination of the sensory nerves, specifically in your thalamic tracts are very highly sensitive for having pain syndromes, but also spinal cord lesions lead to significant pain syndrome. So it's important to think about some of it comes from the actual lesion itself. Some of it can come from the result of long-term effect of lesion spasticity. And so spasticity, when your muscles are contracting up and you can't bend and you're trying to move like a loose spaghetti noodle, but you're an uncooked spaghetti noodle, it's very hard. But sometimes pain can come because of what we would call a secondary symptom, alterations in your musculoskeletal system. So if you're having spasticity and you can't bend your knee, you're hiking your hip up to be able to walk. Well, guess what? Your body was not meant to do that. So when you keep hiking that hip up for a period of time, you're going to be walking some way that your body was not supposed to, and that may cause you pain. There are other comorbidities that can contribute to pain. So persons that might have diabetes, hypertension, any other type of comorbidity, depression, anxiety. And so it's important to recognize what might be causing pain, because when we look at what might be causing pain, that helps us better decide how to manage that. So when we're looking at central nervous system pain, we're looking at most of the time medications in combination with rehabilitation in helping persons learn to use their body correctly and giving them a nerve pain medicine. Most nerve pain medicines are not controlled substances. So just so that you know, when I say pain medicine, it's not what we consider controlled substances. Some of the newer classes of medications, the FDA has controlled them, but they're very loosely controlled. So just, and then we always have to worry about potential side effects. So as we're giving persons these medications, we have to worry about side effects and of course, the financial concerns. And when we look at pain arising from spasticity, again, there's dietary measures that can be incorporated. So if you have a spastic bladder, you don't want to be drinking too much caffeine because that's going to be causing you significant. But if you have even spasticity of your trigeminal nerve, stimulants can also make that worse. Being dehydrated can make electrolyte problems worse. And if you don't eat well and you already have electrolyte problems, you can accentuate that. So it's important that you work on those things. And then the most important thing beyond medication with spasticity management is stretching and exercising and keeping yourself as loose as you possibly can. I was talking to a person yesterday, or the day before, Thursday, in my office. And she came in because she was having significant walking difficulties, which isn't typical for her. But what she said to me is that, you know what? I don't understand it. I lay my bike down. She was describing how she gets on this bike, and I'm just looking at her like, oh my gosh. Because here I'm watching this person, having difficulty get in my room. And she lays this bike down, she gets on this bike and she rides. She says she'll go for 2-hour rides. She'll even have her feet hooked in those things that so your foot doesn't fall out. And I'm thinking to myself, oh. And she rides for 2 hours and she says, when I get off the bike, I feel fabulous. I feel fabulous for maybe about 30 to 60 minutes. And then I examine her and I watch her walking and whatnot, and I start discussing with her what you did for that 2 hours was you were stretching. You were moving your legs. When you first got started, you couldn't get on that bike. You had to lean that bike over. You got up and then you were able to slowly get started. You were loosening those muscles. Your brain, the circuit was and so when you got off that bike, you still had a little bit of that, but then when you stopped moving, the rest of the day, your muscles became tight again. They became stiff. It became hard for you to walk. And so that's a prime example. And I'm not telling you to get on a bike and ride for 2 hours. I'm not in any way saying that because she's amazing. But just stretching, just moving, know when you start initiating a movement that it might be a little bit painful because of spasticity, but the more you move, the more you stretch, the better off it will be. Most medications that we give for spasticity have significant side effects, can cause persons a great amount of fatigue. And so that's something to consider. And financial issues are always in everything. But the other thing is injury. So when I help a person who's very spastic become looser, I have to help them recognize you're used to walking or using a limb that's spastic. You're used to having that tone. Well, now I'm going to make it much easier for you, and that might actually contribute to a fall until you get used to it. So being careful with that. So usually I try to combine that again with physical therapy. So pain that arises from your gait, again, physical therapy and orthotics are best ways for that. And I encourage persons to think about orthotics and things not only as helping with pain relieving, but also helping with fatigue management. And most orthotics don't cause any side effects, and so it's really great. And so severe intractable pain, there are some individuals, because of where their lesions are located, will have severe intractable pain. And in those individuals, we may wind up making a referral to a pain management doctor or considering surgical options where they go in and do what we call rhizotomies, trying to actually kill nerves so that they can't communicate. When we talk about the different types of pain more specifically, trigeminal neuralgia is a very common pain in MS, but it can happen in people that don't have MS. But it's an electrical shocking type of pain. Persons will be like winking if it's happening in their second branch of their trigeminal nerve, or even in the first branch. Their eye will be winking because it's such a searing, severe pain. It does not last for long. It's seconds, but it can occur again and again. And it feels like it's there all the time because it's occurring all the time. The most effective management for this has been seizure medications like carbazepine, phenytoin, and Lamictal. Lyrica is one that we can use, and it's now out in generic, pregabalin and Neurontin. Baclofen, also, that we use for spasticity, we can use for trigeminal neuralgia. And then there are surgical options. Surgical options are not as commonly used in persons who have MS as they are in people who do not have MS, because the trigeminal pain, the trigeminal neuralgia that people with MS have is inside the brain, the trigeminal nerve inside the brain. The decompression surgeries and radiation surgeries are for persons that have it after it comes out of the brain, and it's the peripheral part and it's branching into the face. So that is not always an option for persons who have MS. When we look at neuropathy type of pain, so neuropathy, when persons think of that, they think of many people have neuropathy. If you talk to a group of persons, you're gonna get a lot. I have neuropathy. And typically neuropathy is a peripheral nerve problem. But again, your peripheral nerves start in your central nervous system. So if you are having some of the locations, lesions in your spinal cord and in your thalamus that cause these pain syndromes, you can get some of this peripheral nerve type of burning, tingling, itching, pricking, buzzing, vibration type of pain. I've had many persons come in and tell me, well, I felt like something was on in my back. You know, the phone, something was there. I felt like something was going on. And so that's a typical descriptor of nerve pain. Oftentimes, nerve pain is best managed with antidepressants. And so, I always remind persons, I'm not treating depression. When you go to the pharmacy, unfortunately, I'm using this off-label. They're not going to question that because these medicines are dirt cheap, so they're not going to question that I'm prescribing something for you off-label. But you're going to get something that says this is what it's used for, meaning what the clinical study said it was used for depression. So then people call me back if they weren't listening carefully and say, I'm not depressed. Why did you think I'm depressed? And we use that at a very low dose compared to what's used in depression. So nortriptyline, amitriptyline, trazodone, Cymbalta, which is duloxetine, those are the most commonly prescribed antidepressants for pain. And then, of course, we can use the anti-seizure medications too. Narcotics are not very helpful with nerve pain because narcotics are meant for acute pain. They are meant to interact with the chemical process that's going on in your brain when you have acute pain. So they don't really work well for nerve pain. When we are looking at spasticity, stiffness, muscle rigidity, like I talked about, medications that we use for this, baclofen, Xanaflex, which is tizanidine. Sometimes we will actually use Valium and other muscle relaxants like cyclobenzaprine, Robaxan, those type of things. CBD and THC, this is where they are most effective in reported studies. And then, of course, there's complementary therapy. So when I say complementary therapy, this is something to do in addition to and can be done without a prescription necessarily. physical therapy, stretching, yoga, Tai Chi. And so I encourage you to participate in MS Views and News's virtual programs for these therapies because they are very helpful to many persons. I wanted to spend just a half a second talking about cannabis and tell you what the American Academy of Neurology has said. They have come out with an evidence-based statement saying that they do believe that oral extracts and synthetic THC can have a effect on persons who have spasticity and pain. And so they are sanctioning that this is something that should be offered to persons. Unfortunately, again, it's not federally accepted. So in the cases of wanting to use medical marijuana, here in Florida, there is a website that you can go to. You can put in your zip code, just type in medical marijuana in Florida, and it'll come up with this ominous label. And it's the Organization for Medical Marijuana, and you just put that in there, put in your zip code, and it will come up with the most recent certified state prescribers for being able to prescribe medical marijuana, and you can also learn how to get the card and all the other things. There is some that are being made by pharmaceuticals, and so those have not been proven to be more effective than a medical marijuana. So again, talk to your medical marijuana, and you're going to wind up talking to the person in the dispensary because they're going to be the most helpful, because the person who gives you the medical marijuana is going to give you a note that says you can go to a dispensary. I encourage persons not to smoke. Your lungs are meant for oxygen. Your lungs are meant to get air in, pull oxygen out of that air, and give that to your brain. Your brain is the biggest user of oxygen. If you hurt your lungs, your brain is going to be suffering. So I am all for anything, but don't smoke it. Don't vape it. Don't do anything that it has to go through your lungs. There's lots of edibles, there's pills, there's all kinds of ways that you can get this. There's lots of creams even. So there's lots of ways that you can get it without having to smoke it. And so again, it's important that these be offered to persons as a way, but there are side effects, and we do know that you should know about the side effects of these drugs. And so some of them can be dizziness, drowsiness, difficulty concentrating, or memory disturbance. I want to let you know that so far, that was when medical marijuana first started coming out and becoming much more popular. We didn't have studies, and still we don't have the level of studies to tell you, but so far everything that our neuropsychologists are demonstrating is that persons, when they are not under the influence of medical marijuana, then their cognition is not affected. So, if you are under the influence of some drug, it could be one of those antidepressants that I'm using to treat your pain that makes you a little bit tired. It might be harder for you to concentrate and do complex tasks if it's sedating you. Well, if you're under the influence of cannabis and you're drowsy and you have difficulty concentrating, the good news is, if you're not under the influence, that's not a permanent effect. So there is something that is legal that some people use for pain, and I didn't put up here, but alcohol. I have people who tell me that, they take a cocktail before they go to bed because it helps them sleep. And of course, first thing I'm thinking to myself, okay, that can't work unless they don't want to sleep very long, because it goes into the reticular activating system very quickly, puts them out. But then when they come to, when that alcohol wears off, they're wide awake. So I don't know how that works. But anyhow, Just so that you know, alcohol is a toxin to the brain. We've known that for many years, despite the fact that it is legal and you can go just about anywhere and buy alcohol, even on Sundays nowadays. It is a toxin to the brain, and so it will contribute to brain atrophy over time. It will contribute to cognitive difficulties. And if you have balance problems and you're under the influence of alcohol, I can assure you that your balance problems are not going to be any better. So if you are using that, keep that in mind. Other types of pain that sometimes people describe are this Lemiet's phenomena, and that's where persons will say, I move my neck down like this and I get this jolt of pain that comes down my body, and it. Some people describe it as, it's not too bad, but other people describe that as it's like literally they were shot by a gun and they feel like it is going to throw them to the ground. So again, it can be very individual. But it's kind of sometimes hard to treat because it comes and goes. For many people, it comes and goes. It's not there all the time. So that can be quite difficult. Neck and back pains are typically pains that come as a secondary symptom. But again, there's pain medicines that we can give for that in physical therapy. It's important to think about non-pharmacological treatments for pain because, again, this is what I call complementary medicine. This will help you. Pressure, heat, exercising. Sometimes acupuncture works for individuals. Cognitive behavioral therapy is very helpful in training your body to respond differently. Relaxation, hypnosis, and meditation can also be very helpful with individuals. The key thing is that you really have to be able to describe your symptoms in detail to your healthcare provider. Because if you can't tell us about it, we can't help you. And then we start asking, well, where is it? How long does it happen? When did it start? And your eyes are getting glassy and you're like, oh, it's bothering me right now. And it seems to bother me all the time. So you might want to keep a diary and be open to multiple ways that we may want to treat them. So another invisible symptom is cognition. And so we know cognitive impairment has occurred in MS, and we know that it is part of the disease of MS. It's a primary symptom, and it can be present in as little as 3% of persons, but there are persons who have there are higher percentages depending upon the degree of cognitive impairment. And for some people, it is the only symptom that disables them. For some people, they look fine, and they're all the time hearing from people, "You look so good. You can't possibly have MS." But they do. It's a cognitive impairment. Sometimes it is early as the very first symptom they have. It does not always correlate with the state of disease you're in. And it is not always related to MRI activity. And so this is something that is important. We also know that cognitive decline will happen in persons that are severely depressed. So there is a cognitive issue coming from MS, and then if you get depressed, that's going to make it harder for you to use your brain. So in case you didn't know, anyone who is depressed or anxious is going to have some difficulty using their brain. And so very sadly, decades ago, we used to think that, there wasn't such thing as cognitive impairment. They're all just depressed. We know cognitive impairment is a real thing, but yes, if you're depressed on top of that, the severity of your cognitive impairment will seem more. So it's important that we treat this. It's important that we look at this individually. It is not correlated with your physical function, and it's not really correlated with age-related changes with cognition. So it's important to keep that in mind. It can happen early and can affect your life. So as with all MS symptoms, there is quite a bit of variability in this, and so it's important to think about that. We know that the lesions that are most responsible for this are the total number of lesions that you have, because that is going to contribute to brain atrophy. So we know that brain atrophy, and so when we look at the third ventricle width, this is what we had historically before some of the packages that we have now to measure brain volume. So the third ventricular width, the measurement was how we measured brain volume. So atrophy, we know, is a huge predictor of cognitive impairment, especially thalamic atrophy. So looking at ways to keep your brain from shrinking is extremely important. Symptoms that can happen, persons can become very apathetic, meaning they really don't care, and then, who cares? They're indifferent, or they can be very euphoric, and typically, again, this is not necessarily with depression. When we look at the things that are not affected, so typically procedural learning activities are not affected. General intelligence is not affected. Basic attention is not affected. And somatic memory, the general information of facts, being able to know certain things, is typically not affected. But when we look at what is affected, processing speed becomes affected. So people say, I've got the word on my tongue, I can't think of it, blah, 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 blah. And they think it's their intelligence, their somatic, but no, that's just, they have it in there, they just can't get it out as quickly. Complex attention, multitasking can be very difficult. Executive function, persons will oftentimes make decisions in a whole nother way than they did prior, not think through things, and so that can be problematic. Or they can be the exact opposite. They can't make a decision because they're thinking this, that, and the other. And so I have several patients who tell me they would never go to a restaurant that they're not familiar with, or they would never go to certain places without a family member because it would take them too long to be able to make choices. Word finding difficulties, episodic memory, forgetting facts, experiences, your working memory, and encoding things into long term can be difficult for persons. So when people complain of this is for you to keep track of, and for your family members, the words on the tip of your tongue. And so that phenomena, the person say, it's right there and I can't get it out. The wrong word came out. You meant to say pool and you said ocean. You're blanking out in a familiar area. I can't tell you how many people have told me, well, I got to your office, but I don't really remember turning on Maitland Avenue. And so difficulty following directions or conversations. And so that this can make it very hard in the workplace for persons, especially if they change a computer program or something. People will withdraw from social activities because this is not like Alzheimer's. Persons with Alzheimer's, they don't have a memory problem. They're just fine, and they're going to be arguing with you that you have drugged them into this person's office. Whereas a person with MS recognizes they have some difficulties, and so then they retreat into a safe spot. I don't want to be showing these to the world, so they don't socialize as much. Sometimes personality changes can occur, and defensiveness can be one of them, but other times people have no self-awareness or not as much self-awareness, and maybe you see somebody who has MS that you haven't seen in years, and they've always been this really nice, polite Southern lady, and they walk up to you and tell you something that you're like, oh my gosh, I can't believe she just said that. And it may require assistance with ADLs. So when we look at the preservative type of areas, difficulty shifting in principles, making problems difficult for persons to get from one objective to another. Again, immediate memory is fairly normal, but recent is more dramatically affected. So if you go home today and you're wanting to tell somebody about what I talked about, and you have a significant cognitive difficulty, you might forget some of what I talked about. And if that happens, good thing is it's being taped so you can listen to me again. And so they perform better on recognition than free recall. So, I tell family members that please help them out. Give them a couple of things to help them out if you know that this is a problem. So when we look at the prevalence, again, studies have shown that 43 to 70% of persons will have some degree of cognitive impairment, and it usually progresses very slowly. So that's the good news. When we look at dysfunction, again, it's an invisible symptom. Persons are in denial of this. Family members may be in denial of this. And we do know, just like with all other cognitive difficulties, the more educated, the more reserve you have, the slower your decline is going to be. So education helps. Physical activity helps. Playing games help. So if you want to slow down any brain atrophy beyond taking a drug that will help with that, you need to do the physical and mental aerobics that will help with that. So typically, cognitive impairment is the gold standard is neuropsychological testing, and that can be very cumbersome. It takes 3 to 5 hours to complete, but it gives us a full differential of what could be happening, how much might be from MS, the lesions of MS, how much might be from other factors like sleep disturbances, pain. And it helps us with disability evaluations, because nothing is harder than an individual who looks so good that tries to go for Social Security disability. And they're like, So when we look at neuropsychological testing, it's a combination of a ton of these things. And so you don't need to know this, but we can use some of these in the office. And if you've ever been in a clinical study, you may have done the PACEAT or the symbol digit modality test. And so some of these have been used in office. What neurologists commonly use to evaluate persons with cognitive difficulty is the mini mental state exam, MMSE. We know that this is the least sensitive. So in MS, this is the very least sensitive. So if you go in with your mother, father, family member, and they're being assessed for Alzheimer's, and then you go in and you tell them you're having cognitive difficulties, and they pull out the MMSE that they gave your family member, tell them, no, that's not going to work for me. So what can we do once we find this? Again, the biggest thing is retraining, remediation, using things that can help person, behavioral type of compensation. But we do know that sometimes some of these medications that are stimulants will actually help people think better. And so the one I don't have listed up here that is not a stimulant that I have heard repetitively from my patients. This is not in a journal anywhere or in a clinical study, but dalfampramine, Ampera, has been one of those drugs that has helped many persons think better. Aricept has been also helpful with episodic memory, which is donepezil. Just so that you know, there is no FDA-approved drug for MS cognitive difficulties. There's not. And so that will be a little bit difficult for us. So I tell persons, look at things that you can do to help yourself. So help to restore, again, staying active, preventing injuries, compensatory type of things, using devices. So, I don't know. I carry my phone with me all the time. Most people do. And so, this thing, I don't know whether if you're using it to help you with your memory or just want to make sure that if somebody calls you that you have it with you. Again, use things. These type of things have helped persons out tremendously. So use them. Use routines. So doing the same thing all the time. I tell persons, if you are always losing your keys have got to find a home. And wherever that home is, the keys always have to be there. And that's a training yourself. When I walk in the door, the home for my keys is right here. So that means I can't walk in the door and walk beyond there, go into the kitchen, and no, you have to put the keys in their home so that you can remember where they are. So that takes training and habit. And the other thing is you might need somebody to help you. And so that's a big thing, getting persons to help you. But again, like with other symptoms, you need to treat MS. We need to keep your brain from having more lesions, from shrinking. You need to treat MS. So I wanted to touch on shared decision making, as Stuart asked me to talk about this. And I want to preface this with most of the shared decision making that's out there, and even the IOMSN helped me out a little bit with this, is meant to educate healthcare providers. There's not much in the literature about patients. It's all for healthcare providers. Go figure. Shared decision making. The definition of shared decision making is that it is a key component of patient-centered care. It is a process in which clinicians and patients work together to make decisions and select tests, treatments, and care plans based on clinical evidence that balances risk and expected outcome with patient preferences and values. So, right there, shared. Go back to kindergarten. And those of us that are a little bit older, when we went through schooling, we were not taught about patient-centered care, even nurses. And all nurses do is care for patients. But we were always taught that patient-centered care, or keeping the patient, was doing the best things for the patient. And that's the best that we know. That's not what you think. That's what we know. And so there are many examples of how that works these days. And sometimes it's scary, sometimes it's not. But why should we try to have shared decision making? Well, we know with shared decision making, patients engage in shared decision makings. They do these things. They learn about their health and understand their health conditions, number one. They recognize that a decision needs to be made and are informed about the options. They understand the pros and cons of different options. They have the information and tools needed to evaluate their options. They are better prepared to talk with their healthcare provider. They collaborate with their healthcare team to make the decision that is right for them. And they are more likely to follow through on that decision. So that's why the move from healthcare providers is to try to engage persons in this shared decision model, because it's good for you. And the American or the Academy of Quality Health Improvement, ACA, has a approach that they teach healthcare providers, this share approach. And the first thing that healthcare providers should do is seek patients' participation. Help your patient explore and compare treatment options. Assess your patient's values and preferences. Reach a decision with your patient. Evaluate your patient's decision. Does anybody think that they get that when they go into a healthcare provider's office these days? Okay. I won't digress too much, but I have to tell you about many places are trying to use this. And not too long ago, within the last year, my son was in the hospital. And of course, his mother was right there with him, despite the fact it was COVID, and he's 30 years old. And but his mother's a nurse, and I was right there with him. And this nice nurse came in, very nice. The nurses were very, very nice. And they told him that he needed to have an NG tube put in, which is a tube that goes in your nose, nasogastric tube, because he had an obstruction in his bowels. And of course, the nurse tells him he needs to have this. Well, she doesn't tell him he needs to have this. She asks him. She tells him that the doctor has ordered this because of this, and I would like to put this in you. And of course, my son said no. So I'm like, whoa, wait a minute. And of course, the nurse was all over me because they're taught to give patients the right to make decisions. And so I had to step back. I'm like, Tricia, this is a moment for you to either make a total A of yourself or to help this nurse. Because does anybody know what was missing in that piece? The part that was missing is the part that I was about to help my son with, the education. He did not understand his options. He understood that nurse wanted to come in and put something inside of him that was going to be uncomfortable, was going to make him cough and gag, and then he'd have to have this hose going to. He understood that clearly, but he did not understand the options. So you have to be able to help in decision making when you can understand the options. So when a healthcare provider is talking with you, you have to you cannot make a decision if you don't understand your options. So it's very important that you do that. And to that end, I will tell you that MS Views and News has a place in my office, and all of my patients get literature from MS Views and News because it is the best patient education source for patients who have MS and their families. You get YouTubes, you get all kinds of things, but it's enduring information that people can get from not just me. So it's very important. When we look to barriers of shared decision making, again, this is from the literature of healthcare providers. So the barriers that we see are cultural differences, family dynamics, education level, generational differences. Believe it or not, my son was very good with making that decision. He thought he was. But, somebody who's closer to my age may be saying, are you not supposed to tell me what to do? And so quality of life, what does a person perceive as their quality of life? Time. Time is the one thing that patients as well as healthcare providers agree on 100%, that time is a barrier to shared decision making. The continuity of care, I tell you that is a huge process. People, most of you may be changing your insurance in the next month or two because it's the end of the year, going to the new year. And so is it going to be that your neurology team is on your new plan? Is your primary care doctor on your new plan? Access to healthcare resources is a problem. Transportation issues, cognition, denial or depression, and where do people get information from? If persons are coming into the office to have a discussion with me and they got their information from a blog that is all opinions and has no scientific data to it, then it might be very difficult. So, how can you, as a patient, overcome these barriers? Well, again, I would go back to that share thing. First off, you have to share your values. You have to tell us what's important to you. What is important to me is not what's important to you. I can't imagine what it's like to live in some of your shoes every single day. I can't imagine getting up in the morning another half an hour earlier because I can't feel my fingers and it's hard for me to button the shirt, or I don't wear button shirts. Or I wanted to show you, I have this new belt somebody bought me. And this belt, see how it connects here so that you don't have to take it off? That's what they call, what do they call that? One of those, oh gosh, it's a click. But anyhow, so there are different ways that you can, but you have to share what's important to you, share what's difficult for you, share what your goals are. My goal may be to keep you from having any disease activity, but that might not be your goal. Your goal may be, well, I want to be on something that meets this criteria. So make sure that you are sharing those things. Become informed. You cannot partake in decisions if you're not informed. And that leads to getting reliable sources, but it also leads to the fact that to be informed means we can't do everything on the very first visit. I can't present a diagnosis, tell you about 23 to 25 drugs, have a discussion with you about your values. What do you do? We can't do it in one visit. And even if I could get it all done in one visit, you can't process it in one visit, so you might need to be able to go away and come back. Well, that may be a financial burden. I can't tell you how many times already this month I have people send me messages through my portal that says, well, why do I need to come back in and talk about that? So again, you have to think about that. If you want to have time in your appointment, by gosh, arrive on time. If you don't arrive on time, then you've already eaten up part of your appointment. Even if you know, she's always late. I get there on time and I never get back for a half an hour. Well, that's because the person before you or whatever. So if you don't arrive on time and we happen to be on time, then, but arrive on time. It's important to prepare for your appointment. And so what does that mean? That really means at the time of diagnosis, you should be having a portfolio. You should know about you. You shouldn't come into an office, well, don't you have my medical records? Well, the check's in the mail. I'm sure it's somewhere around, but it's not here. I don't have it. Well, I don't remember this. I don't remember that. You should have a portfolio. You should know about you. You should be able to share that. So come prepared for your appointment. Come prepared with, okay, when I leave the appointment today, these are the things I wanted addressed. Have them written down. Be able to talk about them. And so when I want to talk about something else, you say, whoa, Tricia, the biggest problem for me is I'm having this headache. No, don't get away from that head. So again, make it easy. Make it easy for yourself. Have persons in your home give you feedback on what you're doing, how you're responding to medications, what symptoms you're having. So it's very important to be aware of those things. When all is said and done and you're getting ready to walk out, or your healthcare provider's getting ready to walk out the door, feel free to stop them and summarize what you heard. Because did you hear what they thought they said? Did you get what you wanted? Look at your list and look back and say, okay, yes, I got the things that I wanted. So shared decision making truly is the fact that you come to an appointment willing and ready to help us make a decision. One of the things shared decision, again, we are educating you. It is our responsibility to make sure that you understand. It is our responsibility to educate you. But you have to be receptive to that. But you cannot make a decision if you're not educated. So again, it takes time and takes effort. And if it's done well, it is the best for everyone. So now we have, the reason you came to this talk is to be able to ask me questions. So any question, it doesn't have to be about what I talked about. But any question you have, I am game for doing my best to answer. I ask persons not identify that you're, again, I'm not here to give medical advice. So don't be telling me, well, I have this. What do you want me to do about that? Because I'm not your healthcare provider. So keep it generalized the best that you can. And we'll go from there.
Hi. Thank you for doing this. so appreciate your time. Isn't she beautiful? Doesn't she do a great job talking to you all? That's great. That's great. You know, before I get started with the Q&A, I want you all to know that I'm going to go around the table. You do not get the microphone anymore. All right? That's just the way the environment is, right? So if you want to ask a question, you got to have a mask on, and I will put the microphone in front of you, but you have to have a mask on in order to ask a question. If you don't have a mask on, I can't have you ask the question. I'll have to stand about 6 feet away from you, and you'll have to call out the question to me, and I will then call it out. Before we get into any of that, though, I want to let you all know, before we get into the Q&A, I got to let you all know that I forgot something at the very beginning. I'm so used to virtual and this monitor being on in front of me, which it wasn't today. And we had exhibitors here today, and I hope that you could appreciate that they were here to sponsor the event. We had Novartis, Bristol Myers, and Janssen, and I want you all to give them a round of applause and say thank you. All right, and at the very end of this program, we still have that little raffle that I promised you all that we're going to do, all right? And somebody will feel good for the holiday, all right? So that'll be good as well. All right, so in the meantime, I know that Patricia just spoke about a tremendous amount of stuff that I didn't even know. I didn't even know she was going to talk about today. So I'm sure you have some questions for her. And just raise your hand so I know where to go walk over to. Who's going to be first? We got to have a first. Okay, great. See? We got a first. And she's got a mask on. Isn't that great?
Well, first of all, I'd like to say to Patricia that I certainly appreciated all the information you gave. I really don't have the question because it was in such detail, seriously. Okay, and I don't have questions, but I do have a comment I would like to make to the MS News and Views and News. And that was, during this pandemic, my husband and I definitely appreciated all the virtual programs. I mean, the information that you gave, letting us know the effects and everything that was going out there for COVID was extremely helpful to me. It really was. And I do appreciate the program. And we looked very forward to, and that's how we learned about you, Patricia. So I do appreciate it all. Thank you.
Thank you. Thank you. All right, I have a question. CMSC people just announced that the new studies that they were doing on the SARS-2 COVID and its effect and what's happening going forward with Omicron and other things. Can you tell us more about that?
Well, so we know that MS is not an independent risk factor for doing more poorly with COVID. And there's so many things that we are still learning and writing the book on COVID. But what we do know is that persons that are vaccinated do better. So we buy insurance not so that we don't have something happen to us. So I buy auto insurance not so that I don't have a car accident, but I buy auto insurance so that if for some reason I do have a car accident, it's not as bad. I have some help. So we know that persons that are vaccinated can get COVID. We know people that have had COVID can get COVID again. So we know that can happen. So vaccines are not live. They are safe for persons that have MS, okay? We recommend everyone that has MS get vaccinated. And I've had people come up and say to me, but it hasn't been studied. And I remind persons, when we do studies for MS drugs, it hasn't been studied in diabetes. It hasn't been studied in heart disease. It hasn't been studied in persons who are severely depressed, in persons who have other conditions, any number of conditions. When we are bringing anything to the market, we get the most pure population we can because we want to know the effect of that drug or whatever we're doing on the population. So yes, it has not been studied in persons who have MS. Although we are, and every drug company that has a drug in the market is looking at their people and trying to come up with reliable data on what their titers are. So let's think about, what does a vaccine do? A vaccine is introduced to your body, and it's your immune system looks at that, recognizes that. In the case of the MNR vaccines, the Pfizer and Moderna, it's attaching a little spike, a protein spike, on to your immune system, so that your immune system will recognize that protein and attack it much more quickly. So it's not altering your DNA or anything else like that. But anyhow, if you have a weakened immune system, are you going to have the same response as a person who does not have a weakened immune system? I bet you could tell me the answer to that. No. And I bet you already know that the response that we get from vaccines, those of us who have normal immune systems, is much more than we need to get. It's way above the curve of what we need to get. And so if you get a weakened response, you are still getting some response. And in many cases, that weakened response is in that effective curve where you do have enough to prevent yourself from getting that you're being vaccinated for. Now, time will tell us as to how that works out to be, but that's what we believe. I have been told from individuals, should I get the booster or should I get the vaccine, the third vaccine? If you have an opportunity, not every place that are giving third vaccines is giving a true third vaccine. Some of them are giving boosters, and so it means you're getting partial. You're getting a partial, not the whole thing. But if you ask, you can go, and if you have a weakened immune system, I would tell you, get the third vaccine. Still, there are many reports of, well, I got the vaccine and this happened to me, that happened to me, the other happened to me, and we don't have validation of some of the things that people are talking about. And so just like I tell persons with MS, well, yes, this drug could do this to you, it could do that to you. These are rare things that can happen with this drug. But now let's talk about MS, because that's the elephant in the room. And people want to talk about, oh, the drug does this, it does that, but let's talk about what happens if we don't treat MS, because that's a guarantee. And despite the fact that COVID is not the guarantee that we thought it was, that there are people that died of COVID that shouldn't have. There are people that lived from COVID that were like, wow. But a guarantee that you're going to get sick. And that sickness may last for a very long time. A disease-modifying drug is not more likely to cause you a problem. It is your level of disability and your other comorbidities. And so the data that we are bringing out of CMSC is the COVID data, which we are analyzing persons, either healthcare providers, or if you have MS, you can register yourself in this database as to what drug you were on, how long you've had MS, what your symptoms of COVID was the disease of COVID confirmed? In other words, did you have all the symptoms and you're sure you had COVID, but you didn't go have a test and so it wasn't confirmed? So we're looking at all of that and gleaming from that as to what we can be more assured to tell persons. And out of the meeting in just went past in August, we can tell persons, you need to be vaccinated. You need to be vaccinated.
Okay, next, we do have a question over here from a masked person.
I think I heard you say that the booster and the third shot are different. Is that correct?
So there is a booster, which is a partial vaccine, which is not the whole vaccine. So most persons who are going to get a shot, a third shot, are actually getting a booster, a partial vaccination. If you are immunosuppressed, you can get a, quote, third vaccine. So it's the same amount of vaccine that you got at 1 and 2 or 1. So if you got the Johnson & Johnson, you only got 1. If you had either the mRNAs, you got 2. So if you're immunocompromised and you check that box and you're in a center that has both, you can get a third vaccine, not a booster.
How do you know what you got if you didn't specify?
Shared decision making, shared decision making, shared decision making. So how do you know? Well, they were supposed to educate you what they were giving you, so they flunked on that part. But you were supposed to know when you left. What did I get? How are you going to be able to tell? So that's an example of you went in, you thought it was good, they didn't educate you, they gave you something and you walked away.
So what happens if people cross between using a Moderna and Pfizer?
Good question, and we have not found that, although the vaccine centers will want you to stay with the same brand. Persons who have switched have not had terrible things happen to them. They haven't fallen out and died or anything like that. But the basis of the vaccine is the same. The mechanism of action is the same. But might you respond better to one than the other? That's what we are still trying to figure out. And so some people want to go and get the opposite so that they feel like they've got full coverage. But you are not boosting something that you didn't get the first time. So from a scientific thought, since the difference between these vaccines is not highly different in their efficaciousness, I would tell persons get the same vaccine so that your immune system is not having to chew up anything different, but can make that jump to the higher level of recognition.
Okay, next one here.
I was wondering, I know I should get the flu vaccine. I know I should get the Shingrix vaccine. I was wondering which pneumonia vaccine I should get and other vaccines that you recommend for people with multiple sclerosis.
Very good question. Thank you. So I ask persons to get anything that is non-live. So both of the pneumonia vaccines available are non-live vaccines. So if you're wanting to be vaccinated, the issue is you walk in and say, I can't have something that's live. They should be asking you if you have a autoimmune condition or if you're immunosuppressed, and therefore they should give you extra counsel if you are choosing to take a live vaccine that probably is not good, but you can take anything that is not alive. That's why you can have the flu vaccine versus the nasal flu.
Question.
I was wondering, how come you have to, like me and my daughter went, because she has MS, to get her vaccination, and they told us we had to come back on the 21st because we had to wait exactly 6 months.
I don't know about that. I'm sorry that happened to you. And I do know that some vaccine centers are holding to that rule. Not all are. I tell persons, my patients, if now that there are 3 shots available, I'd like you to get 1 every month for 3 months. I would like you to bring up that level. And then once you've had those 3, you can go to whatever the recommendation is going to be. And I'll be the first if you haven't heard, but I believe, I don't know it to be true, but I believe just like the flu vaccine, we'll probably be getting a COVID vaccine for the rest of our life on an annual basis, because the variants that are coming out, the reason you get a flu vaccine every year, and in case you didn't know, the flu vaccine that you get every year is brand new, brand spanking new, because it's made that year based off of the variants of the flu that we know are prevalent. So it's not the same flu vaccine, and you think, oh, flu vaccine's safe, I've been getting it for 20 years. Well, every year you get a different vaccine. And so every year that we get a COVID vaccine, I believe that what's going to happen is they're going to include these variants. If they're not, so far, thankfully, the MNRs have been proven to be effective against these variants, but they might find something better. So I believe that's what's going to happen. So I'm sorry that they didn't load you, but they should have. And for persons that are immunosuppressed, the CDC said that they could, so I'm not sure. Again, it's all about supply and demand. If they didn't have a big supply and had a huge demand, they may have been holding to a law.
So that was something that we brought up at recent programs as well, that with all the different flu strains that happen each year and the modifying of the different flu vaccines for the different strains, the same thing will happen with the COVID and all the different variants. So I don't know how they're going to change the mRNAs, though, to, how they're going to modify those to the synthetic things, but I guess we'll all find out, right? Pfizer's ahead of the game on this one.
Yes, they are. And the thing is, it's hard, but relatively easy to do. Once we are able to identify strains, I'm not going to say it's easy, but in a lab, somebody can do it relatively easy. It's just knowing the variants that are out there and then having faith that this is something that is to help you. And I please, despite the fact that I'm standing up here telling y'all you should be vaccinated, it's your body, shared decision making. You choose what you want to do. And so back when I was in second grade, there was no such thing as shared decision making. They marched us through the nurse's office, and we all got vaccinated. There was again, it's a decision you need to make, but it is one of the decisions that, for me as a healthcare provider, is most frustrating right now, because the information that is out there is not accurate. People are talking about crazy things like it's going to, you're going to be able to be tracked. That's a big one. Well,
do they know, though, that their GPS and their cell phones are tracking them already?
Yes, I hope so.
That's right.
But the other thing is I had this patient, an educated patient. So I don't want you to think that I'm not aware that this happens in all spheres, all types of individuals. But I had an educated patient tell me, in 2022, I'm going to blow up. That the vaccine is a mechanism, so it's going to wipe out the population, and in 2022, I'm going to blow up. So, if I'm not here next year, y'all know that, but I don't think that's the case.
I get to hold the mic.
Oh, okay.
You don't get the mic
I
anymore.
don't get to hold the mic. Tricia, something else that I like to talk about when people say that it hasn't been studied is, when you look at the amount of people who have taken these vaccines, it's in the hundreds of thousands of patient years. And so, it's been studied a lot more than any of the other drugs that we're taking, as far as, now that it's out and people are taking it. So, it's not that it hasn't been, it's been looked at, it's being looked at. So I always like to.
And so that's a very important point, that when we look at studies, a study of 300 people versus a study of 300,000 people has much different. And so some things that have come to market and turned to be very safe and very effective were only studied in 300 people. Whereas these vaccines have been studied in huge numbers before they ever got emergency use approval. So, and we are continuing to look at them.
All right, new subject. Let's talk about your the things that you were talking about with trigeminal neuralgia. All right, I didn't get to hear everything, but you were talking about. Did you speak about the gamma knife?
Yes, I did.
Okay, what other therapies did you get a chance to speak about?
Well, we talked about decompression surgery and radiation. So the gamma knife is a form of a radiation type of surgery where they're actually going in with a probe and frying, so to speak, the trigeminal nerve. But there are ultrasounds therapies now that they are perfecting in being able to change nerve cells, and so there will be some ultrasound therapies that I'm sure will be available. And there is the good old-fashioned surgery where they go in and actually put a spacer between the trigeminal nerve and the temporal artery where the root of the problem.
Do you know any holistic therapies that are being used?
Well, there are people that are using acupuncture. There are people that are using the oils that they rub on their temples. I have had persons tell me that. I have had people tell me that medical marijuana and CBD oils have been helpful. And so there are, and then hypnosis has been another thing that persons have described with because again, this is such a searing pain. And that's behavioral training type of therapy. So I have heard of those that have been very effective.
I get trigeminal. I haven't found anything that works yet. I'm still examining if I want to try a freight train, but I do want to continue living. But that's how bad it can be. So, yes, I have tried all the other things, and I just wanted to hear if you had something else.
Well, I have a really good acupuncturist. I'll give your name.
That's good, but that's a long commute. All right, you got to wait till I get to you with the microphone. No yelling yet.
Is that acupuncture in Lakeland, Orlando?
The person that I use most is in Maitland.
That's okay. I'm on a 6-month waiting list at the VA, so.
Oh, okay.
Can I ask one other?
Nope, you're only allowed one.
No.
When you said the cannabis, my friends will tell you I don't do anything normal. The shingles were in the ear, but when I do indulge, I get an hour window. I want to vacuum. I want to change the sheets on the bed. I want to do this. I get really energy for a little while.
That's great. I'm glad that that's working for you. But you know, when you're telling me that story, what I'm thinking about, I'm happy that your pain is relieved. The other side is, well, when your pain comes back, you also have used up every single spoon you had, because when you didn't have pain, you did all the things that, you're not, and so then you're physically exhausted and have pain, and pain and exhaustion. So God bless you. Oh, that's so sad. Oh.
Let's go back to the conversation about cognitive changes. And you were saying that there was no specific medication for improving cognition among people with MS. What can you suggest for someone with slow processing speed?
So slow processing speed oftentimes is helped by the stimulant medications. So all of the Nuvigil, Provigil, Adderall, Ritalins, all of those medications have been useful in helping persons that are having processing problems.
Thank you.
Okay, that was going to be my next thing. What about those that we were talking about that are having difficulty finding words. And instead of using the pool, they may use the word stool or fool, things like that. It's hard to talk to people like that and can't finding the right word. But even in general life, I mean, I know that there are times that I walk into a supermarket and I'd be walking down the aisle and it looks like everything is ready to cave in on me and I cannot figure out where I want to go for the next aisle to pick up what next item. Is there anything that controls that for the MS community?
So there's a couple things. So compensatory mechanisms. So when you're walking into a grocery store, you may want to have a list so that you know what it is you're going for if you get disorganized or if you get sidetracked. So you walk into Publix and you see all the BOGOs. Oh man, I got to get this, I got to get that. And then all of a sudden, what were the 3 things that, so-and-so asked me to bring home? And so a list is helpful and can reorganize you. The other thing is when things are coming in on you, is it that you are getting hot? And hot does not mean that you're sweating or that you are out in the sun, but a slight increase in your metabolic rate can heat up your brain just enough that you have short circuiting and then things look like they're coming down on you. So again, being able to step back, sit down for a minute, relook at that list may be helpful.
Okay, so again, this is not about me, this is just a general question, right? The whole thing was, because I know that people have this, but they tell me that they have lists. They go into this store, okay, and still they feel like the walls are closing in on them because there's just too much around them and their brain is being fried from all the information being the stacks of all the merchandise that are there. And they get to a point where they're clueless. They could look at their list and say, okay, I have no idea where it is. They could look at the stuff on the shelves and say, I know it's here somewhere, it's right in front of me, but I can't find it.
That is quite disabling, and so I feel horrible for an individual like that. But one of the things I would say, if the list, if focusing yourself, if all of that is too much information for you to get, then that's where on one of the slides I said, please accept help.
Exactly.
And so sometimes it's just not worth it. It may not be worth going to the store to put yourself through that. One of the many things that have come out of COVID is the fact that so many services are available to regular persons. So you're not identifying yourself supposedly as a disabled person because everybody can do this. You can make a list, you can go shop online, and then you can go sit in the curbside pickup and they'll bring it to you.
That's good.
So, and you can start and stop that process. So if you're shopping online at your favorite grocery store, you can put a bunch of things in your cart and you can, I'm overwhelmed by the same thing as now. Now it's on my phone. You can put it down, you can go refocus, do something else and come back. Decide what is worth it. Everything you do, you have to decide, and again, in that particular situation, many people are doing that have no disability at all. And it's just much more convenient for us to do that than go run through the grocery store.
Okay, I have a question behind you.
I know one of the things that helps me when I'm overwhelmed in the grocery store and things feel like they're like a tunnel, I use a scooter. It takes so much pressure off the walking and the carrying stuff and where I'm pushing. I can sit down, I'm relaxed, and it cools me down because I'm not walking, so I can better focus on what I'm doing. So that may help people.
Okay, thank you. We only have a few moments left, so I can only take a few more questions.
Tricia, I was going to say, when things like that are happening where you find that you can't do things that you could do a year ago, isn't it important that you share those types of things with your doctor as well to let them know that, there's things that you can't do that you used to be able to?
Yes, so when we talk about disability, We talk about the report card for MS. It's MRI, lesions, disability, and relapses, and in any order you put them. And the fourth is being able to take your disease-modifying therapy. But if you're in love with your disease-modifying therapy, and you're not having any MRI lesions, and you haven't had any relapses, but it's Christmas time this year, and you can't put up the tree in one day. It takes 5 days to put up the tree. Or you can't fathom going to Gaylord Palms with your family because the even if I got a wheelchair, it's still all of that. That's way too. Those are the type of things that you need to share, and your family members can help you with that. But when I'm talking to people themselves, I ask them to remember events, because sometimes things are happening to you gradually. You might not appreciate, well, I started wearing a different type of belt, or I'm not wearing heels anymore. You might not think of that as you gradually make those changes. But when you think about one time point and compare that back to what another time point was, are you doing things less or differently because you have become more disabled? And so that's very important for you to, again, shared decision. We can't make a decision, an accurate decision, if we don't have good information. Crap in, crap out.
Great, that's it. I don't think we're finished now with the questions. Thank you. Thank you much. All right. So firstly, thank you very much for all that you've done with MS Views and News over this year, last year, the years prior. Always a good thing, right? Okay, cool. Thank you. All right, I was going to have to do something if you said no, but that's good. Thank you. All right, so again, everybody, I want to thank you all for being at this last live program for us this year, and we do hope to be able to get back next year. Hopefully, things will be better. Maybe we'll find another area somewhere in this portion of the state, to come back and do a program again, and it would be a good thing. It would be a good thing when we could all say we don't need these anymore, right? At all. So the only way you can really do that, though, is tell your family and friends, it's really advisable for them, their health, to get vaccinated, as well as it'll make it easier on everybody else around them, and we'll get rid of this thing quicker. So, I used to say at the beginning of this whole thing, I can't wait to see if I grow a tail between my legs. But I didn't. Okay, and I don't have a third leg, and I don't have other things happening, so I feel very fortunate. And I did get started very early as well. I mean, when the vaccine came out, it was the beginning of February. I was getting a vaccine, so and then just a short while later, again getting the follow up, and then going forward and getting boosted. I mean, it was a great thing to have. So, and I look forward to when they come out with this again, so I could get another sore arm. All right. Anyway, thank you everybody for doing this, and hope to see you all next year. You keep on doing that. Go ahead, a little louder. Get everybody to do that. There you go. Thank you.